if you think about who is the person in the hospital that you would call if there were a problem, and the answer in every hospital across the country is going to be a general surgery chief resident. As a med student, it's really stressful. You look at all these things that you can do, and you're like, gosh, I have to make this decision right now before match day that's going to determine the rest of my life. And while that is true, it's less true than you think it is as a med student. I tell people general surgery all the time is not one specialty, right? Like general surgeons, I am so very different in my day-to-day life than, say, a trauma surgeon.
Yo! Today we got to talk with Dr. Dawn Elfenbein about why general medicine is the best specialty. She herself is a general surgeon, and she also completed an endocrine fellowship. She completed medical school at Johns Hopkins School of Medicine. She also completed her general surgery residency at Duke. Then she completed her endocrine fellowship, which is only 1 year, at the University of Wisconsin. My conversation with Dr. Elfenbein was really cool. I loved it. We talked about all types of stuff, and I can't wait to do future videos with her in the future. If you haven't liked and subscribed by now, and you're watching this, and this is your like 4th or 5th episode, me and you are gonna have a problem. Papaya with a little bit of lime. All right, sweet. All right, so Dr. Elfenbein, thank you so much for coming into to one of my videos on choosing a specialty. I really appreciate it. You're the first attending, so like, hopefully I have my A game on. You know, the set was like hopefully set up really well, pretty quickly I think today. But I hope it's smooth through the video process. We had a lot of hiccups, but this time it's gonna be good, I think.
Well, thanks for having me. I'm excited to be here and talk about it. You know, I like to talk about things or write about things. I'm a verbose person, so I'm happy to talk to you and anybody else who's interested on this topic.
Thank you so much. Thank you so much. So I want you to know before we get started, every specialty kind of has their day.
Yeah.
So let's just assume we have respect for them. So today, this is all about you guys.
For sure.
So I want you to unapologetically tell us why general surgery is the best specialty in the world.
Yeah.
Okay. So that's what we hopefully accomplish today.
Sure.
So first, could you tell me a little bit about your work schedule? Like, how was the last couple weeks?
Yeah, if you, so I have a work schedule, as you know, I'm a general surgeon, but I have subspecialty training in endocrine surgery, and I work at an academic medical center, so I have roles outside of my clinical practice. So on a given week, I would say over the past 3 weeks, interestingly, I will do that. I'll start 3 weeks ago, because 3 weeks ago I was on general surgery call, and general surgery call at our sort of satellite hospital means that in the morning I wake up, I come to the hospital at 6:30 in the morning, and I get sign out from what happened overnight. If anyone who needed emergency general surgery came in overnight and was still waiting to have surgery. So for example, someone with appendicitis came in around midnight, and instead of calling in the overnight team at 2 in the morning when they knew that the patient was ready for the OR, they just waited and put it on my schedule for 7 in the morning. So for an entire week, I came in every day at 6:30, not knowing what was on the schedule, but taking care of whatever happened. So appendicitis, gallbladder, small bowel obstructions, things like that. So it was patients admitted overnight and then patients that get admitted throughout the day, and I take care of those patients. So for the entire week, 6 days that week, Monday through Saturday, and then a couple of nights that were thrown in there just for good measure. That was my job, and that was it. And I had time for nothing else. So my email piled up, you know, by the end of the day. Sometimes I would go in and kind of cull the emails down a little bit, but every other part of my job kind of takes a backseat when I'm on that service. Then
how often are you on that?
I only do 5 weeks a year, so I don't do that much of that.
Oh, sweet.
Yeah, but it puts everything else on hold. It puts my elective clinical practice, it puts all my med student teaching and things like that kind of on hold. Last week, then, I was back on my regular schedule, which is different every day. So Monday, I operate in the morning, and I have a clinic in the afternoon, and that's my my endocrine surgery practice. So I usually do a thyroid or two in the morning, and then I see about 10 clinic patients in the afternoon. And then Tuesday is my administrative day. So Tuesday is my day that I have back-to-back meetings, but they're not all meetings. So I start the morning usually on Tuesdays from 7 to 8 teaching med students. We do a virtual kind of case discussion with all of the med students that day. And then I usually have a little bit of time to do just sort of administrative things myself, go through email, kind of get through my to-do list. And then at 9 o'clock, we have a meeting with our fellow. So our fellow, who is the most trained, basically after residency, you can do fellowship. And so our fellow is learning how to do endocrine surgery. She presents all the cases for the following week to us. And we kind of have high-level discussions about endocrine surgery cases. And then for the next whatever that is left of the day, 6 hours, there's a variety of different things that I do, from administrative meetings, from, things that go with the whole med school, where we talk about the curriculum of all the medical students and how surgery fits into that, to, I now have this vice chair of well-being role. So sometimes I'll be sitting and talking about how we're going to implement a peer support program within the Department of Surgery or things like that. So really varied how my day goes on Tuesday. Wednesday, I usually operate either Wednesday or Thursday. And then the day that I'm not operating of those 2 days, I'm doing, again, designing curriculum, having meetings, talking to people, kind of doing that. And then Friday is usually another clinical day.
Oh, wow.
Yeah.
Okay. Friday's a full clinic day.
It's usually a half a clinic day.
Okay.
And then the afternoon, again, is more time to do other things. So I'm usually operating 1.5 to 2 days a week. I have a half to a full day of clinic a week spread out over 2 days. And then all the rest of the time is all of my administrative teaching kind of stuff.
Okay. So on your, employment contract, is there, a split between administration and, specialty?
Yeah, at this institution, it's not so clear cut. I do have what we call protected time. So there is, you're considered to be one full-time employee,
right? And
then there's percentages of time that you are protected or paid to do those other roles. And I have, the med student role, I had about a 30% protected time. I have a 5% role in our hiring committee within our department. And so there are certain things, I would say, because that changes sometimes when I get new roles and things like that. So I'm about a 60% clinical person, 40% some mix of other things.
Gotcha. Mm-hmm. Okay, sweet. That's really cool. I feel like when putting that into your schedule really provides so much variety to your work life. So it feels like that isn't although that sounds super busy, it's that change of pace, doing things that you love, that are teaching med students, designing curriculums, doing all that other stuff I feel like that really adds some spark to your life every week,
It does. You mentioned to me before this interview that you get bored with things easily.
Oh,
I think I get bored with things easily too, or I just don't like all of my days to be the same, right? It's exciting to me to come in and say, this is a clinical day. I can completely forget about all those other things, right?
Yeah.
And that's the kind of secret about being a surgeon too. Even among doctors, the surgery or the OR is kind of this black box that people think is really important. And it is. It's very important. Yeah. But if someone sends me something and says, this is urgent, and it's on one of my surgical days, I just say, look, I'm in the OR today. I'm not going to get to it till tomorrow. Sure. And the answer is always okay, that's fine, which is really nice, right? Because if you were to say, someone sends you something and says, this is urgent, then you get all this stress because you're do I have to stop doing what I'm doing? Yeah. How urgent really is this? Yeah. The OR really does sort of overshadow everything else.
Oh yeah,
which is nice. And I try not to take advantage of that, obviously, but it is really nice that it does give you a little bit of leeway to be able to put things on hold and not have that constant barrage of things that seem urgent and fires that need to be put out.
That's awesome. That's awesome.
Yeah.
Okay, so speaking about general surgery, could you first, let's start off with an elevator's pitch.
Yeah.
Could you just tell us why straight up you love general surgery?
Yeah, I always go back to if you think about who is the person in the hospital that you would call if there were a problem, any kind of problem, it's a clinical problem, I'm talking about a really sick patient, and the answer in every hospital across the country is going to be a general surgery chief resident, right? A general surgery chief resident has taken care of patients who are dying and shot in the operating room with trauma. They're taking care of ICU patients. They're troubleshooting things in the operating room. So working with their hands, they have these skills to like do anything possible. And it's from, here all the way down to the pelvis, including all the extremities. It's everything. It's the entire body. It's the physiology of really sick patients. And it's really understanding the pathophysiology of sort of the disease processes behind that. So I always say general surgery chief residents are just like, they're the go-to people for anything that happens in the hospital, right? They can walk into a situation and come up with a solution.
Yes.
A clinical situation.
You have just.
I wanted to do that.
That's really good. That's really awesome. You honestly answered my next question, because I was gonna ask, like, why the heck is this called general surgery?
Yeah.
When honestly, especially when I rotated,
Right.
it just looked like 99% GI surgery.
Yeah, it's it's a different specialty than it used to be. I mean, it used to be 100 years ago that you were a surgeon or you were an internist, right? That you did the procedures or you didn't, and then things started branching off of that. From neurosurgery became its thing, orthopedic surgery became its thing, urology became its thing, and so what was kind of left behind was that basically anything from your chin down to your pelvis, so the entire kind of thorax, including the neck, and down to the pelvis. And even now within general surgery, something like 80% of residents go on and do a fellowship of some sort. So even within general surgery, as we add more complexities to operations, operate on different things, it used to be general surgery, you used to know how to do, 50 operations or so.
Yeah.
Now general surgery encompasses, 1,000 different operations, because you don't just do an exploratory laparotomy anymore. Now you do a laparoscopy, and now you can do robotics, right? Every single way of approaching the body has changed over time and become more complex. And so because of that, you just can't know everything about general surgery anymore, right? And so the subspecialists really narrow it down. But I think most general surgeons say the broad base of training there is really, really, really valuable to them as they go on and do more subspecialized training.
This is a specific question to you, but also honestly, I feel like I've seen even people that do just general surgery. A lot of people tend to focus on like a box of surgeries. Like, for example, like one general surgeon would like be the go-to person for surgery that treats chronic esophageal reflux.
Sure.
And then another one is like the go-to person for something else, you know, hernia repairs or something, right? So, and I like that your answer was very specific. You said like if to be honest, if anybody had any choice, you choose a chief resident in general surgery.
Yeah.
So like, what would you say about like the attending life? Do you feel like especially for you, like you did a year fellowship in endocrine, a lot of your specialty practice is endocrine surgery, but you do like 5 weeks of general surgery on call. Like, how do you? I feel like that's scary for me. Like if I leave something for 10 weeks, like I'm just done. Like I don't know anything about that specialty anymore, you know?
Yeah, I mean it changes, right, as you go from med student to resident to attending in terms of just your skills and how long those skills stick around. I remember being a third year resident, and it was weird where I did my residency, we instead of getting a week or two of vacation at a time spread out throughout the year, we had a month of vacation every year, and that was it. You had to take your month block all at a time, and then you would come back. And after being gone for a month, when I was a second year, third year resident, I was like, I'm going to forget how to operate. I don't know how to do this anymore. A month is too long. And now I have no problem not operating for a while and coming right back to it. The skills really are skills that build on one another and they stick with you. And I, as an endocrine surgeon, I do adrenal surgery. So I'm operating in the abdomen in my elective practice as well. I feel like doing that general surgery call both helps sharpen my skills for adrenalectomy and vice versa. The fact that I'm doing adrenalectomy means I'm in the abdomen all the time. Now, I will say that there are certain things that have evolved since I finished training. Like, for example, doing laparoscopic inguinal hernia repairs and femoral hernia repairs was kind of just starting out when I was a resident. And when a new thing starts happening when you're a resident, the interesting thing is the attendings first need to learn how to do that themselves. For those cases, attendings were scrubbing in together and the residents weren't really getting those skills. And so I don't have those skills. And it's something that I could do if I wanted to, but to get really skilled at doing a laparoscopic hernia repair. You probably have to do 20 or 30 of them.
Oh, yeah.
So I would have to kind of take a break from my endocrine practice, get those patients somehow to come to my clinic to like learn on, right? Or I would go to, say, Mike Guerin's clinic and I would operate with him on those.
Right.
But if I operate with Mike Guerin to learn how to do a laparoscopic inguinal hernia, that means 20 operations don't have a resident learning how to do those. And for what, right? For me, in the 5 weeks that I take general surgery call, maybe 1 or 2 patients come in with an incarcerated hernia that would be probably better fixed laparoscopically, but I don't have those skills. I can fix it open. I can take a patient to the operating room, make an incision, put the hernia back in and fix it.
Yeah.
Or I could call one of my minimally invasive colleagues and say, you know, I'm gonna take this person who's got an incarcerated hernia. We'll push the hernia back in, so I'll make it so it's not emergent. And then tomorrow, I think you should fix this person laparoscopically, right? We work together in a collaborative way when it comes to those things that are a little bit more subspecialized that maybe aren't a part of every general surgeon's training. So it is often a negotiation and a discussion when it comes to those cases that maybe I don't have the skills for because they weren't a part of my skill set in general surgery training and they're not a part of my fellowship skill set, but they are good for patient care. So how can we work together as a team to come up with the best way to take care of these patients? But make it so that the MIS surgeon that does a ton of these isn't the person that has to be woken up at 2 o'clock in the morning every single time someone comes in with this, right? So, yeah, it gets complex.
Oh, yeah. So it seems like those TV shows, you know, Grey's Anatomy and all that, like when they show like this kind of gunnery mindset amongst the surgeons, like, I need to get in on this case. I need to have this type of experience. It's actually pretty real then. Like you really need as much hands-on experience to really learn. Like your learning happens in the OR.
Yeah, absolutely. Yeah. I think, you know, and I think that residents sometimes get a little frustrated I think this is true of any surgical specialty, that they want to be the one doing the operation, right?
Yeah.
And I think that we just had a grand rounds a couple weeks ago where one of our chief residents talked about the value of second scrubbing. And you know this because you're a med student, right? You know what it's like to be standing one person back from the actual person doing the operation. And as a med student, it can get quite tedious. I get it, right? Standing there with a retractor in your hand, you know, like looking at the wall. Like I remember being a med student and thinking that like 2 hours of an operation doing that feels like 2 days, right?
1,000%.
Whereas to the attending who's really focused in and dialed in on the operation, 2 hours time passes like nothing when you're in that flow state. And so I realize that there are people that have different attentions in the room at the same time. But what this chief resident was talking about at his grand rounds was if you're not a med student, let's say you're a 3rd year or 4th year resident that has acquired some of those skills and is really working hard on those skills when you're the person doing the operation with the attending, you actually don't get a good sense of the big picture. So doing that same operation, doing the operation with the attending, right, being scrubbed in and doing the operation, and then the next operation maybe be the med student role. Stand back for 1 second and let someone else struggle with the actual skills while you get a bigger picture and kind of can take a look at the operation and see what's happening as somebody else is struggling with the skills, right? Taking that sort of mental step back where you can take some of the mental imagery and predicting what the next step is going to be without being in that stressful moment of I'm actually doing these skills right here.
Right.
He talked about how valuable that is, and I think we've lost that over time because everyone's so focused on operative autonomy. I have to be the one doing the operation every single time, but I think there's value in sort of taking lots of different roles. So that was a long answer to your question of should you scrub in a lot? And the answer is yes, but it doesn't mean that you necessarily have to be the one doing the operation to scrub in. I think there's value to taking a really, really focused attention second scrub role.
Oh,
right?
Yeah. That's beautiful. I think that totally makes sense to like really try and figure out how to find value in that second role. Because I mean, that's obviously the med student story, but it's a more frustrating story as the resident because you're there to master the skill yourself.
You are. And it's hard as a med student to really have that attention, right? Because you haven't been doing it. You haven't been the one struggling to throw that one stitch or to see that one plane. And so if you haven't been in that role, it's hard to take a step back. The things that you're doing as a med student is like, you know, staring at the neck being like, oh, is that the carotid or the IJ? Or is that, and so the level of questions that you have and the level of observation is different than if you are further along in your training. But there's value in those things too, right? So there is value. It's just different as a med student. I get it.
For sure.
Yeah.
All right. I have a few pros that I wanted to mention, and I'd love your commentary on. I think one of the coolest things that find a specialty appealing to me
Mhm.
is like their fellowship options.
Yeah.
And general surgery has probably the most fellowship options I've
Mhm.
ever come across.
Yeah.
You guys have trauma.
Yeah.
You can be a trauma surgeon.
Yeah.
These fellowships like range between like 1 to 2 years, right?
Correct.
Okay.
Mhm. Yeah.
There is. Oh, sorry about that. There is breast,
Mhm.
endocrine.
Yep.
You can focus on just minimally invasive surgery,
Mhm.
colorectal transplant. The list kind of goes on for a long time.
Right.
And so I find that to be super appealing
Mhm.
because then you could not only be a general surgeon, but also be something that like endocrine surgery.
Yeah. Mhm.
Obviously, that's super appealing because you get to specialize in something following that. But also, I feel like, does that also open a world to like even better work-life balance? Say
Yeah.
that is
Mhm.
higher on your
Yeah.
like preferential. You
And
know?
it defers your need to become really differentiated as a med student, doesn't it?
Oh,
So,
yeah.
you
Oh,
know,
yeah.
like as a med student, it's really stressful. You look at all these things that you can
Yeah.
do, and you're like, gosh, I have to make this decision right now before match day that's going to determine the rest of my life. And while that is true, it's less true than you think it is as a med student. I think med students really do feel sometimes trapped by that decision that it's going to close all these other doors. But it really does open up a ton of doors. I tell people general surgery all the time is not one specialty, right? Like general surgeons, I am so very different in my day-to-day life than, say, a trauma surgeon, right? And trauma surgeons, their life is really appealing too. Most people will say, oh my gosh, I don't want to be in the hospital in the middle of the night and do all that stuff. They're working all the time. They're not working all the time. They work all the time for 1 week and then they don't work the next week, right? Like they are when they're the way that trauma surgery has gone now, you're in the hospital carrying the pager, dealing with all the crises as they happen for a set amount of time. And then when you're out of the hospital, you're out of the hospital. No one's calling you in the middle of the night. Like I'm an endocrine surgeon, very few emergencies happen. But if I operated on a patient last week who has a problem this week, they're going to call me at 10 o'clock at night, at 2 o'clock in the morning, or whatever, right? I'm always there for all of my patients that I always operate. I don't get to clock out. Trauma surgeons and acute care surgeons, they do, right? They work in huge teams of people. There's somebody there in the hospital to take care of the patients that they were taking care of the week before. And so that's really appealing to some people too, because when you're there, you're there. But when you're home, you're home. Your pager, you're shut off your pager. You're done.
What?
And you can leave. You can go somewhere else, right? Anna O'Rourke is one of our trauma surgeons that has this wonderful place up north and goes there often on her weeks where she's doing administrative stuff, especially now with remote work. You can do work anywhere, right? So that's really appealing to some people too. I find it stressful to not know what's going to happen day to day on those days that I'm there, so I don't love that. But you find different things that appeal to you throughout general surgery residency. Yeah. You kind of find out what's good. But yeah, I think there's a world of possibilities that still open up when you do general surgery.
Could you list off just a few of the ones that are stereotypically known to be like a really great work-life balance? I actually know endocrine is actually known to be somewhere like in the work-life balance world.
Yeah, it is. Endocrine is mostly outpatient operations, so you usually have a very and they're fairly predictable, right? Like I know what my day is going to be like. I can do 3 operations in a day and be done by 3 o'clock in the afternoon. Most of my patients don't stay the night in the hospital, and I said that my patients can call me anytime, but that's really rare that I get some sort of emergency after surgery where someone calls me. The other ones that are, like you mentioned, minimally invasive. I think minimally invasive is also a very nice, sort of good work-life balance kind of thing. Again, many elective operations, those laparoscopic inguinal hernias, laparoscopic Nissen procedures. Within minimally invasive, a lot of people will do bariatric surgery, and those patients do stay the night in the hospital, but again, they do really well. And man, you're curing diabetes, right? There's nothing else that cures type 2 diabetes other than bariatric surgery, and they're curing that. And that's a huge problem. So really satisfying. I think colorectal surgery has a really great kind of work-life balance as well. Again, dealing with a lot of colon cancer, a lot of, ulcerative colitis and Crohn's disease, but also doing sort of the thing that I loved about colorectal surgery is nobody feels more gratitude than someone who has like an anal fissure, which is super painful, but also super embarrassing. You don't go around and tell people like my butt hurts, right? Like you don't do that. And so when you walk into a colorectal surgeon's office, you explain the problem and they say, oh yeah, no problem. Like this is something I deal with all the time. It's normal. A lot of people have it. And then they fix it. Like
That's
so much gratitude.
quality of
right?
life grows high.
Yes,
Yeah.
so much gratitude for those patients. So that I found, I kind of came to that a little later in my residency, and when I realized how great of a feeling that was, like that kind of relationship that you have with patients that they're so grateful for helping you, is great. I think breast surgery is kind of similar to endocrine surgery in that it's a lot of outpatient procedures where very few emergencies. But I think it depends on what you're looking for work-life balance.
Yeah.
That determines what specialty you like. Like I said, I think for me, work-life balance and trauma surgery, that would be hard because I don't like the unpredictability of it.
Sure.
But for other people, they just love it, right?
Yeah,
They have so much freedom to do other things. It's almost like emergency medicine, right? When you're in the hospital, you're there, and when you're home, you're home.
Yeah, absolutely.
Yeah.
I mean, I know Dr. Guerra would be like, or any of those like MIS guys, they're going home like 5 p.m.
Yeah,
Like, you guys too, especially you're done like early as well.
Mm-hmm. Yeah.
So I think I just that's a myth. I feel like.
Yeah.
But I know. Nonetheless, we know that residency is hell. You're gonna you should expect like 7 years, 5 to 7 years, maybe a couple years of fellowship to just like be a life sucker, but you're there to learn. You're gonna learn a lot. It's gonna be something that you love to do.
Mm-hmm.
But in terms of that, like family life or free time, extracurricular stuff, will certainly be there for you in the intending time.
It will. I caution you a little bit about framing it that way.
Sure.
And I caution students all the time about this, is that I think that there is danger because like when you're a resident, you're in your 20s and maybe early 30s, right? That is the prime time of your life to be, forming those critical relationships and starting families and doing those things.
Yeah.
And if you have the mentality of like, I need to wait to do all this stuff until I'm an attending, you're going to miss out on a lot. And a lot of people do that, right? And particularly women, because it's hard to be pregnant and give birth and breastfeed while also working 80 hours a week and doing all this stuff, right? It is harder for women to do that. And I think we're working on it. We're working on making spaces for that, making pregnancy safer for pregnant surgical residents, making breastfeeding more accessible. It's still going to be hard, but I think we do have to work really, really hard, all of us, to change the culture around that and say that it's okay to do that.
Oh my God. You brought this up. I wanted to do a whole video on women in the surgical residency program.
Yeah.
Because I know that is like a huge conversation that needs to be had. I feel like I know there's a culture in surgery where it's like, I feel like some women might feel bad to have a baby. Like they feel guilty, even if they had the opportunity.
Right.
I remember it was quoted, obviously nowhere specific, but somewhere in the country, there was obviously some director or some physician that would say like, you choosing to be here as a resident is like almost kind of like you signing in to not have children. Like you owe it to the program in some way to not do this thing where you start a whole family and take yourself out of commission for a couple months,
Right.
And that culture exists. And so I definitely want to have a deep discussion on that.
For sure, we could get a panel of women.
Oh,
I can think of someone in our department actually who has done a lot of work on this. So looking at not only, so we tend to focus on maternity leave, right? What happens once you've had a baby, and paternity leave. Frankly, I think we're having that conversation more, which is an important conversation as well. But she's been looking at the data about pregnancy itself, being pregnant and working 80 hours a week and standing, 12 hours a day and, all those kinds of things. And the data is horrible, right? I think most women surgeon mothers, the rate of miscarriage is much higher. The rate of early birth and low birth weight and all that is much, much higher than the general population. And it really comes from that mentality that we all have. Women, too. I'm not saying men impose this on us.
Yeah.
I mean, the patriarchy imposes this on us, so I can talk about that in a little bit, but we're all part of that, right? We're all part of this, like, culture of everyone kind of has their role. But we need to put systems in place to make it safer for
100%.
Women to be pregnant, right?
Yeah.
And to support the people who are supporting those women by either colleagues, right? So you're a man, you're a chief resident, and you have 3 female chief residents who are all pregnant. That's a tough situation too, right? Because the work still needs to be done. So how can we fill those in with advanced practice providers or whoever, what kinds of things can we put in place to make it so that we don't send that message that it's not okay to have a kid during residency, because we've never told men that, right? And that's
For
just
sure.
not, you don't
Exactly.
tell a guy like,
Yeah.
nope,
Yeah.
you can't have a kid. Sorry.
Yeah.
Mm-hmm.
Super important discussion.
Yeah.
One of the things that I also loved about general surgery, we kind of talked about other things that I know is like the large skill set. That was in your elevator pitch.
Yeah.
Like these people can do absolutely anything in this hospital. Anybody's go-to is going to be a bad butt general surgeon chief resident, right?
Yeah. Uh-huh.
And so
Bad. Surgeons curse a lot too. So if I curse on this podcast, I'm sorry.
No,
Apologize.
you're
It just
absolutely.
comes out.
You're absolutely. It's up to you, 100%. The other thing I was gonna say is a visual impact.
Mm-hmm.
Like you're able to not only diagnose.
Yeah.
And there's a lot of specialties that do a lot of diagnosing,
Mm-hmm.
but like you actually go and take care of that thing.
Yeah.
And you get to see the results of that.
Right.
And I think that's probably one of the coolest things about it is that you guys are just you're not only the detectives, but you're also the problem solvers.
Yeah. Mm-hmm.
Which is like super cool.
Yeah.
And then there's also like, quote unquote, true lifesaver. Every doctor is saving lives in some way or shape or form. But today's about general surgery. You guys are freaking saving lives literally.
Mm-hmm.
Someone in shock and is going to die in a few seconds.
Right.
You want that surgeon there.
Yeah.
So the current match rate is about, for medical student seniors, MD seniors, is about 72%, which isn't bad at all.
So that's surgery specific, or that's
General
across?
surgery,
Okay, general
categorical
surgery.
programs.
Okay.
And there's about 1,600 spots. And for reference, internal medicine is about like 9,000 spots, which is the largest that's ever been. But like anesthesia is 1,600 as well. Radiology is like 100.
Wow.
So there are like, I don't know, 150.
Sure.
So it's about mild to moderately competitive.
Yeah.
And the step 2 scores aren't like super high either. For general surgery, I have a step 2 score average of 248.
Yeah.
Which is actually not bad at all.
Yeah.
So it's
That's higher than my step 2 score, by the way.
Oh, really? Totally fine. Who cares about step 2 back
I
in
would
your
not
day?
match in general surgery exactly if I had to do it all again.
I think for some reason, I mean, these were a couple years ago, so it was just around the time step 1 was pass-fail. So honestly, if we look at like the data that will come out this year, I bet that gap, that average is going to go much higher now that we have only step 2 to use as an objective measurement. So when we talk about the pillars to choosing specialty, hopefully my viewers have this background, but there's about 7 pillars into choosing a specialty.
Okay.
And it's from this roadmap that Stanford has on their website, and it's a really good one. And instead of talking deeply about each one, we can just talk about. I just want you to rank them.
Sure.
If someone who's interested in general surgery, how would they prioritize this list?
Okay.
Okay.
I haven't seen this list before, so I'm interested in it.
Yes.
Okay.
All right. So it's adapted from this book too, The Ultimate Guide to Choosing a Specialty. I don't have the name of the author in front of me. I should keep that on me.
Yeah.
But anyway, I keep using it. So.
Sure.
So anyways, here are the 7.
Yeah.
Area of scientific or clinical interest. That's this is in no particular order. You're going to order them. So area of scientific clinical interest. So we're talking, if you love anatomy, you should look into specialties that really have a strong emphasis on that.
Sure.
Surgery's on there, radiology's on there, right? Pharmacology / physiology is anesthesia, things like that. So if you obviously hate, urology or cardiology, don't be that specialty.
Right.
Preference on surgical, medical, or mixed specialty, right? That makes total sense. Actually, that's typically like the first question people always say, like, oh, do you want to be a surgeon or do you want to do medicine? Number 3 is types of non-medical activities you want to engage in. That one, honestly,
I feel like that's within work. Yeah.
Exactly.
Because work-life balance is a later one that you're talking about. So
exactly.
I feel like
you're exactly right. This has to do with research, academics. Is that readily available to you?
Yep.
I think that's all true for general surgery. So no issues there. Amount of patient contact continuity, patient population, work-life balance, and earning potential.
Yeah. It's so hard to rank that list for general surgery because, as we talked about, general surgery is not one thing anymore,
Yeah,
right? It
yeah.
opens a bunch of doors for different things. So
Sure.
something like, work-life balance, I think, is something all students should think about. But within general surgery, again, you have those specialties that are very shift work, and you have those
Sure.
specialties that are very continuity, and you have those ones that have 14-hour-long operations, and you have ones that have 2-hour-long operations. And so it really does, there is the whole spectrum of work-life balance within general surgery.
Yeah, yeah.
So that
That's
comes
beautiful.
later.
Okay.
Yeah.
So to make this, okay, that's really good. So
Mhm.
in other words, you're saying that it doesn't matter how you order this,
Right.
because you can find this all there.
Yeah. Mhm.
So what was your top 3 though when you chose your when you chose
Right.
general surgery?
I think that for most surgeons will tell you that there is something that happens when they're in the operating room. You have to love being in the operating room. You have to love operating on patients. If you don't love that, then don't choose surgery, right? Like that has to be the first hook. And
So number 3, okay.
yeah, I would say
number 2.
Number 2, I think as a med student, you probably know. You either walk into the operating room and you say like, "Oh, this feels like a place I could spend some time." To get a little mushy on you, like it felt like the first time I walked into an operating room, like I felt like I was home, like a home I'd never been before, but I felt like I was home. And so, and many surgeons that you talk to will explain sort of a similar thing, that the operating room, they just feel, you can like relax in the operating room.
Really?
Yes. And I know a lot of med students walk in the operating room, they're like,
Yeah,
I do not want to be here.
honestly, no way.
I don't like wearing this hat. I don't like wearing this mask all the time. I don't like doing that. Like, I don't
Yeah.
like worrying about rules of sterility. I don't like any of that stuff. And to me, it was fascinating and intriguing, the ritual of it, just it's so different than every other place in the hospital.
Sure.
If you don't like it, you can't be a surgeon. And
Yeah,
and you don't have to like it the first time, but you have to grow to appreciate it through med school. And you'll be able to tell in med school if that's a place that you kind of gravitate back towards or shy away from. Right.
I totally agree with that. I feel like when I definitely, it took me a while to get comfortable, because when I first went in there, I did not feel, I was like, man, I want to be in the hospital. Because like I felt like just too many rules. I felt like I was walking on eggshells all the time, and I knew anybody would call me out on it.
Yeah, right.
which is even more scary and intimidating.
Right.
Having that social feedback.
Yeah.
So I think, but eventually I did feel like once I got the groove of it, I did feel a little comfortable. So I think that you definitely have to know whether or not you're happy in there or not.
Yeah, but gosh, man, Yusuf, you bring up such a point. So you're sitting there as a man of color, and I'm sitting here as a woman, and we're talking about surgery, and we are two groups that were traditionally excluded from this club.
Yeah.
So I think it's really important as a med student, if you are a med student in a group that is underrepresented in surgery, to really think about and figure out if I'm feeling this way because I feel like I'm being treated differently, like I'm not a member of this social club, versus that actual feeling that you get individually in yourself of whether or not you belong in the operating room, right? Because I don't want to discourage anyone who has been traditionally excluded from becoming a surgeon, because I think that we need to get more and more of us to be surgeons to make that club a lot more inclusive and to grow that space. And so I think you do bring up an interesting point, and I don't know if this is why you felt that way.
Yeah, I don't know either.
But it's trying to separate out that is this social cues from people around me telling me I don't belong here, or is this really authentically that I feel like I wouldn't thrive in this environment for whatever reason, because I don't like doing operations, or but like trying to separate those two things I think is really important. And if it's the social cues that are telling you that you don't belong there, find someone. And if the inner pull is telling you that you really do want to be there, find someone to help mentor you through that, and still go into surgery. Please, we want you in surgery, and I will help you too. Anyone in the country who's listening to this podcast, you can call me and say, I think it's that I'm feeling excluded here because I'm an underrepresented background person, but I really feel like I should be a surgeon. Let's help overcome, because there's a whole bunch of barriers on that side of things that we need to work on, but it's that inner compass kind of feeling, right? If that inner compass 100%. Is pulling you towards the operating room, listen to it.
Okay, that's a beautiful message. Thank you so much. So you said number one is to choose surgery.
Yeah.
Is to be someone who's surgical, who's comfortable.
Yeah.
And eventually likes it.
Right.
Would you What's your number 2 after
Yeah.
that?
It's so interesting. All of these it's hard to order and rank them for all the reasons we talked about, that general surgery is so varied. But I will speak about some of them and say why I think that they are important, right?
Okay.
So I think this amount of patient contact and continuity is something that med students get told. When you're a primary care physician, you get patient continuity. And when you're a surgeon or a subspecialist, you don't. You just operate and they disappear.
Right.
I think that is a false dichotomy. I think that there are many areas of gray zone in there. I do have continuity with a lot of my patients, but it's only on one issue, right? I don't deal with all the rest of their issues, but I will follow them for up to 5 years if they have thyroid cancer. So I do have that continuity for some patients on their thyroid cancer issue. I get to know them really well. They bring me gifts. I see them outside of the hospital, right? Like that, you still can get that, but it's true that's not the main thing that you're seeing, right? So I do think just to be cautious if you're a med student and someone has told you that before, that primary care you get patient continuity, everything else you don't. That's not exactly true. You just get a different kind of patient continuity, right?
Yeah.
And you see the same types of patients over and over again too, right? So there's that continuity of sort of your specialty, that you really get hyper-focused on one area of medicine or surgery or whatever it is, versus being much more broad and kind of knowing a lot about everything. So there's that sort of, it's not continuity of patient care, but it's sort of continuity of the pathophysiology of diseases, right? I could talk to you about thyroid stuff.
Yeah.
For 24 hours straight and not repeat myself, and you would be so bored because you're like, I have no interest ever in knowing that level of detail. But getting into that level of detail, I think, is good too. So it's sort of continuity of pathophysiology versus continuity of patients, I guess.
Okay.
And I get a little of both as a surgical subspecialist, I think. So I think that one is fairly important. I would put that up there. So.
Oh yeah.
Oh yeah, needs your face.
It needs my face.
I gotcha. So I think that one can be something that you consider, but maybe not in the traditional way that people kind of counsel you about.
Right.
I think area of scientific and clinical interest,
Varied.
it's really varied too. But I think that people who have an interest in doing things with their hand and solving problems outside of surgery can find ways to marry that with their surgical practice. I'm thinking of people who have a surgical practice and are interested in device development, right? And work with biomedical engineers or something like that. That's a really natural kind of marriage. So if you're a person who is an innovator, an inventor, a person who kind of makes things and tinkers with your hands, surgery is a great specialty because it really does marry with sort of those outside interests. That kind of goes with the types of non-medical activities you want to engage in, right? I would say I'm a surgical educator, and I think that there are fewer of us. If you look at med schools across the country, there are many fewer surgeons involved in higher levels of med student curriculum administration than there are, say, psychiatrists or internal medicine or pediatrics, right? So it is harder to carve out a career in education in the surgical world, I think, than it is in other specialties. Some of that has to do with earning potential, right? So surgeons make more money because you just make more money by doing procedures. It's just the way that our system is set up. And so doing medical education through a med school is usually at some set salary that is based on like an internal medicine salary or so. So to do that work, you're often doing that percentage of time, whatever it is, 20% of your time, you're getting paid at sort of a lesser salary than you would doing the OR work.
Right.
So there's a conflict there. You're always being pulled towards the OR to make more money, but you want to do the education stuff where you get paid a little less. So that is a challenge to navigate in the surgical world.
That's actually something unique to surgery because other people might have, like some specialties obviously shift work, right? And the amount of orders you're doing and the amount of work that you're doing to serve patients. The tests that you're doing, the procedure that you're able to do, you get paid for. But surgeons have this currency called RVU. Right? That's not anywhere else, right?
No, RVUs are everywhere in the hospital. It's just that the RVUs they're more
of an emphasis in surgery or something?
Yeah, they're just more heavily used for compensation in surgery, I would say.
Okay.
Yeah, so for a lot of other things like a hospitalist, you do make RVUs for seeing patients and doing consults and doing those things. You sort of as a group, you kind of have a goal target RVU to do, and you all get a salary.
Oh, yeah.
Exactly. Yeah.
Okay. And could you like really quickly just explain what an RVU is? Like,
Yeah.
how is that determined? Like, what is
It's
that?
it's historically determined by a lot of people over a lot of time. It's a governmental
Gotcha.
thing, right? So RVU is a
Okay.
relative value unit that was put in place when Medicare was formed way back in the 60s, and it evolves and it changes all the time. But it
Okay.
basically says a relative value unit, again, it's like an INR, right? It's like a normalized ratio of some
Right,
sort. That
right,
basically
right.
1 unit of work is worth this much money. And let's say 1 unit of work is doing a new consult in the emergency department, right? That takes whatever, a half an hour to see the patient, examine the patient, write the note. So then they say, relative to that, what does it take to do a esophagectomy, right?
Right, right.
I don't know, it takes 25 relative value units to do an esophagectomy in terms of mental, physical, skill, all those kinds of things. It's a terrible system, and it is heavily skewed towards those things that are very procedure oriented.
For sure.
And it causes a lot of sort of issues, and it's politically motivated, right, based on specialty and all sorts of different things that go into it.
Damn, this is interesting. This is very interesting because I have the doximity report for average compensation.
Yeah.
And so this is the top 20 specialties of all of medicine.
Sure.
And they all make above $400,000.
Right.
General surgery is on that list. You guys average $451,000. And all of the specialties that come from general surgery are kind of almost above that.
On that list,
they're on
Uh-huh.
that list.
Yeah, right.
The fellowships that you guys that come from general surgery obviously make their RVUs are more valuable, I guess.
Mm-hmm.
But you guys, I don't know. General surgery, you guys maybe should be getting paid more, man. I have this really funny video that talks about some of the stereotypes of general surgery. I want to hear some of your reactions to it.
I bet I've seen it. I love this guy.
This guy, Dr. What is his name again?
Glaucoma Flecken, I think.
Glaucoma Flecken.
Yeah. I think he's an ophthalmologist.
Oh, yeah. That's the one fact I actually know.
Yeah.
Sweet. Let me put up the volume.
Mm-hmm.
Interview. Come on in. I need better exposure. Nurse, retractor. Oh, the last applicant didn't even offer to retract during his interview. Well done. Oh, I'll do this all day. Tell me about yourself. I'm an only child, orphaned at age 12.
Nice.
Honestly, that's kind of funny because like I do hear jokes about like beef between internal med docs and general surgeon docs.
Right.
Is that real or no?
No,
that's not real. Okay.
No, I mean maybe, sure. I think that I think that it's heightened more in residency than in attending hood, right? So in residency, it's stressful. You're a resident all the time. You're getting all these pages all the time to do consults and things like that. And so your initial reaction, I think, to a pager going off sometimes to a consult that you have done
I'm here for my
multiple times.
Come on in. I need better exposure.
Because your experience is I've done this so many times is so easy. How can somebody else be calling me
applicant
about
didn't even
this?
offer to retract during his interview.
Oh.
Well done.
But
do
yeah,
this
I think
all day.
that
Tell me about
smooths
yourself.
out a little bit.
I'm an
as
only
you
child,
become
orphaned at
For
age
sure.
12.
Some of my
No,
best
parents
friends are
died?
internal.
No, I
medicine.
disown them. Necessarily.
Beautiful.
Why? They were both
All right, sweet.
internal medicine doctors.
I haven't seen this one before, by the way.
Okay, good. That's so funny.
Excellent.
So
Yeah.
that's another stereotype, right?
Yeah.
That general surgeons have to sacrifice a lot of their like family life. Or in other words, we keep talking about like work-life balance.
Right. Mm-hmm.
And we talked a bit about that. But can someone just truly just be a general surgeon and still make it like perfectly work? Or what is it? Is it because of like you don't know when the day ends? Is that really the thing? Like you being stuck in the OR and things like that?
That happens. And I think, some of the very cliche things that I tell people, but I think that they ring true, is that
So why surgery?
you have to find the
after
right
completing my
partner,
first
right? So
24-hour
if you're
surgical
already
call, I knew I
partnered
wanted
and you're
to feel
deciding to go into
exhausted
general
for the
surgery, you
rest
have
of
to
my
have
career.
really long
What are your
conversations with that
strengths? Tying
person
one-handed
to
knots.
make sure
What
that
are
you're
your
both in,
weaknesses?
right? You
Maintaining
can't just
relationships
be
with family and
the
friends.
one person
No, I
who's
asked
in
for a
and your partner
weakness.
thinks that it's not a good idea. That is not going to work. So you have to have a conversation and say, look, there are going to be times when I'm stuck in the operating room and we had dinner plans and it's just not going to work out. We're going to have to cancel, right? How are we going to respond when that happens? What are we going to do in those situations? If you are not partnered and are going into general surgery residency and you start dating someone, you have to dole it out in small bits and say, look, I work like I started dating my current husband. He tells me that I should call him my current husband, which I think is hilarious, by the way. So I've only been married once, and I plan on staying that way. But my husband, we met when I was in the lab, and I tell people that I tricked him into falling in love with me when I was a normal person, because when I'm in the lab, I have normal hours. We would go out, we'd listen to music, and then suddenly I came back and I was working nights for 6 weeks in a row, and we never saw each other for 6 whole weeks, right? I think our relationship has evolved where he knows that if, it's 5:30 or 6 o'clock in the afternoon and I was supposed to be home, and he knows it's an OR day for me and I'm not there, he just knows I'm operating, and he like adapts and he changes, right? And he and my kid make dinner themselves, or they figure it out. And so you just have to openly communicate with the person that you're with, and you just find the right person and you make your relationship work. It's different than other relationships, but then other people are like, oh yeah, I can't compare it to anything. I've only had this one, right? And we somehow make it work. And is there tension? Yes. Is there tension in every relationship? Yes. Absolutely. Right. So I think you absolutely can. You're going to find tons of general surgeons now who are women, who have kids, who are moms, who are making it work, and it's hard. And then the last thing I will say about that is that you can have it all, but you can't have all of it at the same time, right? So there are times when you're going to be more focused on your job. There are going to be times when you're more focused on your family, and you have to have that flexibility to allow that to be the case. And you're going to feel like a failure at work when those times are that you're having to focus more on home, but you have to just let that go and know that you're going to be able to have that attention at some other time in the future and come back to that.
That's great. Okay, let's see. I think he speaks a little bit more about these jokes. Let's see if he does the same thing.
Mm-hmm.
What is that? I think surgery, like, this is the truth, man. I feel like if I did a poll of med students, it'd be like 99% to 1.
Yeah.
For some reason, being in the surgical rotations is so intimidating.
Yeah.
And everybody knows that the surgeons out of all doctors, could be the ones to snap at you.
Mm-hmm.
So tell me about that.
Yeah, I would argue I would put cardiologists in there as well. So
I'm
gonna
really?
go ahead and throw some other specialty under the bus as well. I think that I believe this less and less over the years, but I said for many, many years that the one thing that all surgeons have in common, the one personality trait they all have in common, is impatience. I think surgeons are very impatient people and have a need to have things happen right now, right? Whether that is, I see a patient problem, I'm going to fix it in the operating room. That's that immediate, instant gratification thing that draws a lot of people to surgery. That translates to everything else. That like I see a, lab value that needs to be fixed. I want it fixed right now. I don't want to wait and have it fixed later. And so that impatience, I think, often translates and comes out as potentially anger or
100%.
Like those kinds of things. So I think that constant, like, this just needs to happen really soon. There's urgency to everything that we do. Happens. And I think it's a little problematic, right? There truly isn't urgency to everything that we do, but we take that sense of ourselves and we apply it to everything, which I think creates some undue tension where it's not needed.
Yeah.
And med students definitely feel that.
Oh yeah.
Yeah.
We feel that a lot.
Yep.
But fortunately, not me though. I had the greatest time.
Excellent. Well, you were on my rotation. You have to say that, right? I already submitted your grade, so you don't actually.
Exactly.
Yeah.
No, truthfully, I was lucky. I was very lucky.
Yeah.
So burnout is a serious concern.
Yeah.
When it comes to specifically general surgery residency.
Right.
And that should be a concern, at least for many people, if you want to consider that as a specialty.
Right.
I try my best
Yeah.
to not think about the difficulties and the struggles of doing a residency if I know that it will be worth it as an attending.
Right.
However, general surgery takes the cake when it comes to struggle,
right.
And so burnout is super real, and it's a high risk in the surgery residency and even as an attending.
Yeah.
So I know. So how are you guys dealing with that right now?
Yeah. I just took on this role in my department, actually. So I'm the new vice chair for well-being in my department. And so we are, we're doing a lot of gathering of information right now, right, of what kind of things lead to burnout. And so, there's the things like the hours, right, that is better than it used to be, but still is not fantastic, right? You're in the hospital a really long time. I think
We're a bit
they're-
softer too. I feel like in
Yeah.
our generation.
You think?
Oh yeah.
Yeah.
I mean, like, we're doing great by
Mm-hmm.
working on burnout. Obviously,
right.
this is a need. Mental health is a need.
Yeah.
However, I can't help but see, and I can't like flick a bunch of examples off the
Right.
top of my head, but I can't help but see that people were successful with the certain struggle. And it's
Yeah.
significantly better,
Mm-hmm.
but for some reason, like burnout is still
Yeah.
high. And maybe
Right.
we're collecting more data too. There's just so
Yeah.
many other questions. I sent you on one track, and now I'm like backtracking
That's
you. I
okay.
guess, like,
Yeah.
I guess you're like now debating against me here.
No.
But-
That's right. Yeah.
But I want to know.
Yeah.
You're saying that it's gotten better, but for
Mhm.
some reason, has burnout gotten better too?
So
Is that
here's-
also improved?
I mean, this is going to be kind of high level talk about maybe even going to the 80-hour work week, right? Because I think the 80-hour work week is a lot of where people start. Like people will say, like, how in the world are you burned out? I used to work 146 hours a week, and you're only working
100%.
80, right? Like
Yeah.
how is that hard for you? I think what is different between 146 hours that whatever my father's generation used to work, because I didn't either. I trained under the 80-hour work week, but 80 hours now is very different than 140 hours before. 140 hours before, when you were working every other night in the hospital and you were sleeping in the hospital and you got to know patients, you were carrying a lower patient load, you had fewer operations to
Ooh.
learn, and you didn't have electronic medical records where you're constantly being barraged by things all the time.
Oh.
So the time spent for 80 hours in the hospital now is constantly being, I don't want to use a negative term like being badgered, but kind of is, right? You're constantly getting HealthLink secure chat messages from people taking care of the patients on you while you're trying to read up for the operation that you're about to do. You scrub into the operation and your pager starts going off and people are doing, so you're constantly being like hit by all these different things and your brain is being pulled in different directions and you can't focus on the one thing that you're supposed to actually be doing. So working on fixing some of that stuff, I think will go a long way for burnout. I think a lot of people think like work-life balance means at 5 p.m. I get to go home and I get to shut off my work brain and I get to turn on my family brain. And I think that that's a very challenging way of looking at work-life balance, right? Like, yes, you should get out of the hospital at a reasonable time, but sometimes things are going to happen that require a little bit of your work attention at home, and sometimes things are going to happen that require a little bit of your work attention or your home attention at work, and that's okay. We can try to set up those boundaries, but really working on burnout is working at what happens while you're actually at work, right? How can we allow people to focus on the things that matter at work? Like create spaces where teams work functionally together instead of dysfunctionally together, because dysfunction on team is so stressful, right? If you have a bad interaction, and you were talking about this as a med student,
Yeah.
you have a bad interaction on that team for the next 6 hours of your workday, you're like, oh God, man, I should have said this, or I should have done it that way, or like your brain is like enumerating on this stuff that happens. That leads to burnout. That leads to at 5 o'clock when you finally go home, you're like, oh my God, I have to shut all this off so I can just like decompress. Like if you could just make it so that didn't happen at the end of the day, you're like, wow, man, I like really feel like I made some progress learning how to do an operation today, right? And I took really good care of my patients. And I really like the team I'm working on. You wouldn't have to have that, like super set, firm boundary at 5 p.m. when you go home. So I think that's what we have to work on. We have a lot of work to do in this space and creating situations and creating teams that are functional and that just take off some of that mental load of the residents that we're putting on them all the time.
That's great. Okay.
I can't tell you how to do that,
Right.
but I can tell you that
But
that's
we're
what we have
working
to
on
do.
it. All right,
Yeah,
sweet.
yeah.
I get that.
Mm-hmm.
How could we? So this is one of the greatest things that I've been interested in hearing from you.
Mm-hmm.
Is how can we use meditation to like unlock that and fix that problem?
Right. Yeah. So that, mindfulness is something that I've been practicing for a while. I think that there's a lot of surgeons that do this maybe in secret. We don't like to talk about this because it sounds spiritual and soft, and, it's those soft skills that we don't talk about in surgery. But, mindfulness is paying attention on purpose to what's happening in the present moment without judgment. And a lot of that stuff is exactly the opposite of what we teach in surgical residency, right? Surgical residency, we say, if you know the right answer, you're a good, strong strong resident. If you have the wrong answer, then you're weak and you need to do better things, right? So that judgment is happening all the time. Surgical residents were constantly feeling judged, and so judge themselves very harshly. And surgical residents, we're always asking them to anticipate the next step, to do the next step thing. So you're never fully focused on the thing that's happening right there in front of you. And so I think working with surgical residents to incorporate some of these skills of awareness and being present, and trying to take off a little bit of that judgment, that harsh sort of emotionally laden judgment that goes on top of knowing how to do something or not knowing how to do something, is really important.
What kind of things can I start like working on? Because I feel like number one, it's hard to buy into meditation. I don't know what I like. Is there? Could you somehow convince me that it's one of the most important things that we should all be doing?
Yeah, probably not in like the few minutes that we have left, but I do think so. I think, the data is really strong, that having some awareness and being present in what you're doing. I can tell you of a study I was just talking to some of my friends about yesterday. I have a group of women that kind of talk about mindfulness things in healthcare professions, and she was bringing up a study, I think it was from 10 years ago now, where they basically just asked people throughout the day, what are you doing right now? What are you thinking about right now? And how happy are you? Those 3 questions, right? And if what you are doing right now and what you are thinking about right now are the same things, then the answer to are you happy right now was very high. If what you're doing right now and what you're thinking about right now are different things, so right, I'm doing this thing, but I'm thinking about my to-do list for the rest of the day, pardon me, then your happiness in the moment is actually less, right? So if you can, and this is a crazy thing, the number is staggeringly high, something like upwards of 70% of the time, that what you're doing right now and what you're thinking about right now are different things. Humans spend most of their lives on autopilot with their mind doing something else instead of paying attention to the thing that they're doing right then, right? So being in that present moment, and that is directly correlated with like that inner sense of happiness and joy and contentment. So if you can train your mind to be aware of when you are doing those other things, planning for the future, remunerating about the past, being anxious about something that's about to happen, you can cultivate sort of an inner sense of well-being.
Holy crap. Is there an app to start this or something?
There is actually. The University of Wisconsin has a Center for Healthy Minds. It's part of the university, but it's also an offshoot of it that has a free app called the Healthy Minds app that you can use, and you can start cultivating senses of awareness, insight, purpose, because I think having some purpose in your life is really important as well. So there are ways that you can start doing
I'm going to download it. I'm going to cruise around it. I'm going to actually
give it a try. I'm not making any money on this. This is just something that I have used in the past, and it is free. And the whole purpose of it is to get, people to sort of have a little bit more awareness of what's going on in their inner life.
Oh my God. That is super clutch. I'm going to give it a try.
Yeah.
And I'll download the app and I'll give some feedback.
Yeah.
Thank you so much for coming. I really appreciate this. This is going to be awesome. I'm so excited for you guys.
Yeah.
If you made it this far, you're welcome. So, thank you, Dr. Elfenbein. I appreciate you.
Absolutely. Yeah. I'll talk to you anytime. Thanks.
Sweet.
All right. That was fun.
That was great.
Yeah.